the best way to do this is by answering simple questions. What is epilepsy surgery? Why do we do it? When do we do it? And who qualifies for surgery? What is going to happen? Simple questions like that. So this is basically my outline. They are all various questions I think normal people have when we are told about epilepsy surgery. What exactly is seizures? What is the basic management? Why must they be controlled? What are the options that are available? What is the spectrum of disease and management? Who gets surgery? What are the common surgeries we perform here? As well as what is the outcome and what happens if surgery is not controlled. So I'm going to try to answer as many of these questions in as simple a way as possible. And I'm pretty sure we can entertain some questions if we have time later. I think Shirley covered this quite well. What is a seizure? Seizure is a single, sudden, stereotypical alteration in motor activity, sensation, or behavior or consciousness. And it's usually due to an abnormal electrical discharge of neurons. And epilepsy is recurrent, unprovoked seizures. So when we talk about seizures, seizures are basically, the brain is like an electric box. So this is a circuit box in our house. And what happens is there's usually a focus of electrical activity, which is uncontrolled. And that usually leads to the circuit box burning out. And that is what ends up having epileptic seizure. And this is basically a simple explanation of what happens, because the brain is very similar to multiple wirings, and that wiring somewhere has gone wrong. And that is what causes an uncontrolled electrical activity, and the house shuts down. The idea here is we want to try to control the electrical activity so that it does not spread and it does not come back again. And we do that with the first step, which is medication. If that is not possible, then we move on to try to remove this area which is damaged. Basically, within the brain, we identify where it's damaged and try to remove that area. So seizure, I think, again, Shirley went through in detail partial and generalized seizures and what are the different types of seizures we have. So I'll just skip this. The management is establishing the correct diagnosis and then decide if a medical management with anticonvulsant epileptic medicine is necessary. Select the appropriate medication. You usually start with single therapy and then you move on to increasing doses or multiple therapies if necessary. Only if medical therapy fails, we would consider alternates. This includes, one of the participants earlier asked us about ketogenic diet, as well as resective surgery, as well as non-resective surgery and neurostimulation. This includes things like vagal nerve stimulators. So the management of epilepsy is multimodal. It's not just a single type of treatment. We start with the anti-epileptic drugs, which is this big circle here. And then if it doesn't work, we combine them with various modalities, other modalities, including ketogenic diet, resective surgery, and neurostimulation. This can be used singly or in groups. So frequently, patients who undergo resective surgery also have got anti-epileptic drugs on board. And sometimes we may do resective surgery and neurostimulation as well. So it is multimodal, multiple therapies. Why do we treat these patients? We treat them because we want to prevent trauma, we want to prevent them from having falls, sudden death. We want to prevent prolonged seizures. This can again lead to multiple complications, including pneumonias as well as sudden death. We want to minimize the impact on development and academic achievement, especially poor memory, cognitive deteriorations. And we want to avoid long-term risks, which include psychosocial deterioration, lack of employment, lack of mobility, as well as secondary epileptogenesis. These are the main reasons we must treat epilepsy. We can't just say, oh, he only has seizures once a month or once every other month. Seizures must be controlled. So going back to the outline I showed you earlier, I've covered the first 4 topics. What is seizure? What is basic management? Why must seizure be controlled? And what are the options? I'm now going to move on to the key topic, which is epilepsy surgery. Epilepsy surgery is surgery to control seizures and improve a patient's life, quality of life. And this includes removal of a part of the brain that causes seizure, or interrupt the nerve pathway to prevent the spread of seizures. So again, going back to the earlier example I gave you, this is the fuse box, and this is where the focus has burnt out. So we identify this focus which has burnt out here, and we either remove this part if it is possible. If it is not possible to remove, we interrupt this connection so that the impulses which are fired from here do not get to the rest of the brain and damage the rest of the brain. And that is the purpose of epilepsy surgery. Who should get surgery? Any patient with recurrent seizures, especially after a good trial of medicine. Patients with debilitating seizures, seizures which are caused by lesions, especially tumors or brain damage. Young children with uncontrolled seizures. These are the main ones who should be evaluated for surgery. Not necessarily get surgery, but at least evaluated for surgery. And age or other illnesses, including diabetes, hypertension, ischemic heart disease, they are not contraindication for seizures. The spectrum of disease we treat goes all the way from curative surgery to palliative. And this can include multiple different diagnoses: temporal lobe seizures, low-grade gliomas or brain tumors, cavernous malformation, mesial temporal sclerosis, frontal lobe seizures, etc., including pediatric epilepsy syndrome. So we've got a whole spectrum of disease. And the treatment we initiate is dependent on the disease as well as the effect it has on the rest of the normal brain. So the procedures can be anything from lesionectomy, that means we find the lesion and remove only the lesion, or sometimes we do something a little bit more extensive, which is lobectomy. We remove the whole lobe where the lesion is included, which in cases where it's not possible, we do simple things like we do hemispherectomy, where we isolate the hemisphere. We can also do disconnection, which is callosotomy. So we disconnect the right brain from the left brain so that they don't talk to each other and cause worsening damage. Of course, you also have got other neurostimulation procedures like vagal nerve stimulation, which actually reduces the frequency and the severity of seizures. So this is a spectrum of diseases and surgeries we perform. So what is the process we use to decide for surgery? The most important thing is pre-surgical evaluation. And this requires an adult or pediatric neurologist with a team experienced in managing epilepsy. We need to do EEGs. All of you will be familiar with EEG. These patients will also need 24-hour video EEGs to localize where their seizures are from. MRI imaging, in this case, is essential. Occasionally, we also need advanced imaging, which includes SPECT or PET scans. We may need neuropsychological assessment. And very rarely in cases, especially non-lesional cases, we may need invasive monitoring. Once all information is gathered, then we'll have a multidisciplinary discussion involving the neurologist, the radiologist, the neurosurgeon, as well as the neuropsychologists and the EEG technicians. And the main reason is to decide, is this patient suitable for surgery? And the deciding factors are, number one, is the is the seizure refractory? Can we localize the site of the seizure origin? Is this focus operable? And can we do this surgery with a reasonable margin of safety and high chance of success? These are the most important things we have to consider before we do surgery. Sorry. So the idea here is to balance the risk versus the benefit ratio. And the benefit must always be better than the risks of surgery. And once we have decided that the benefit is better, only then we offer surgery to the patient. And the epilepsy surgery itself, the team consists of, as I said, the neurologist, radiologist, neurosurgeon, as well as facilities, including advanced imaging, operative facilities. But the most important is experience. And of course, you need to have a neurosurgeon who is specialized in epilepsy surgery. Coming back to the original outline, so I'm already halfway through this, session. We are now going to talk about what are the common surgery that is done for epilepsy and what is the outcome. So the usual conditions, as I mentioned earlier, are lesional. They can be divided into lesional and non-lesional. Lesional means there is a sort of a lesion or a condition like brain tumor, cavernomas, arteriovenous malformation, infected or hypoxic lesions, as well as epileptic lesions, mesial temporal sclerosis, focal cortical dysplasias, etc. The non-lesional, on the other hand, are generalized epileptic syndromes, especially in pediatric age groups, as well as multifocal epilepsy. So these are the two main groups of conditions we usually offer surgery for, lesional and non-lesional. Going to the first one, lesional, brain tumors. So primary and secondary brain tumors, especially cortical tumors in the frontal part of the brain and the temporal part. So the frontal part is right above the eye, and the temporal part is above the ear. So these are the areas where tumors can actually cause a lot of seizures. Similarly, infections, bleeding, etc. in this area can cause seizure. And that I think Sharni showed a number of scans. So these are the areas where seizures can happen, and these are lesions within temporal and frontal areas. So lesional surgeries, complete resection of the lesion and the abnormal area, 92% of them have very good outcome. In fact, more than 90% are seizure-free or reduced. And the next one, we're moving on to the epileptic lesions. The most common type of epileptic lesion we deal with is mesial temporal sclerosis, also known as temporal lobe epilepsy. And this is the most commonly performed epilepsy surgery. There's usually a clear focus of epileptic discharge or EEG analysis coming from the mesial temporal area, which is just about here. And they must be compatible imaging study, which shows that the area is shrunken. In which case, we can actually go in and remove the damaged area. As I said, our aim is to remove the damaged area and to prevent the area from propagating the electrical impulses to other normal areas here. This is very briefly what we do in the surgery. We actually identify the area of damage. We go into the area of damage and actually remove all of this area so that it doesn't cause any more seizure spreading. So the benefits of surgery: there's better control of seizures, 80% are seizure-free or vastly improved. There's better quality of life. There's improvement in their cognition, and it is much more cost-effective in the long term compared to polytherapy. There's also a reduction in the sudden death phenomenon due to epilepsy. There is, of course, risks, which include speech deficit, memory impairment, some visual problems, including something we call superior quadrantenopia, etc. There is a risk of operative mortality, 2.5 in 1,000 patients. However, in our series of cases in UM, we have not had anybody who has actually died due to this surgery. The outcome at 1 year is 76% seizure freedom or improvement, which reduces slightly at 5 years to about 64%. Of course, we do have about 25% of patients who relapse after being seizure-free at 2 years. We also have got extratemporal lobe epilepsy. This is epilepsy outside the temporal lobe. Less common, and usually the diagnosis includes things like focal cortical dysplasias, benign neoplasm, vascular malformations, focal gliotic lesions. The surgical outcomes are not as good as temporal lobe epilepsy, but they still do quite well. The average success rate is still more than 60%. Yeah, I'll just move on. What about non-lesional epilepsy? So non-lesional epilepsy, as I said, is generalized epilepsy, frequently in children, and it involves larger areas. In these cases, we offer something called hemispherotomy or hemispherectomies, especially in cases like Rasmussen's encephalitis, hemimegalencephaly, hemispheric stroke. They usually perform early in life to improve the seizure control and to arrest the intellectual deterioration. Patients can develop hemiplegia depending on the age of surgery. If they're done earlier, their hemiplegia risk is much less. There is also risks of hydrocephalus, coma, etc. The main issue here is we want to improve the quality of life of the patient and the carer. The other common non-lesional surgery we perform is corpus callosotomy, especially in cases of drop attacks, Lennox-Gastaut, etc. And in these cases, there may be a risk of interhemispheric dissociation. The surgery reduces uncontrolled seizures and prevents patients from injuring themselves, and helps with better control with anti-epileptics. And the last one I want to talk about on non-lesional epilepsy, if all this doesn't work, then we actually consider vagal nerve stimulators. Vagal nerve stimulators are adjunctive therapy. They reduce the frequency of seizures. They are used in patients above the age of 12, especially when we can't operate on the focus of seizure. And we have done a number of cases in UM, and we have found that the success rate is actually much more than 60%. These patients actually reduce the number of seizures, they improve their quality of life, and they actually are quite happy with the surgery itself. There is a short-term risk of infection, vocal cord paralysis, and facial nerve paralysis, as well as a longer-term risk of stimulus-related throat pain, hoarseness, and coughing. This is basically what a vagal nerve stimulator looks like. So we actually insert this electrode into the neck area, into the nerve we call the vagus nerve, which then is connected to a battery here. The battery sends out impulses into the brain and controls seizures. We have got a newer version of this vagal nerve stimulator, which can actually be used as on-demand simulator, where we can put a small magnet on top of this, and that simulates electrical impulse into the brain and aborts the seizure when it's happening. So these are all new technologies that are coming up to help patients with seizure. We'll move on to the outcome of epilepsy surgery. Outcome is usually defined in 4 groups: complete seizure freedom, improved seizure control. The first 2 are the best, and then there's no improvement of seizure control or worsening of seizure control. And the predictors of favorable outcome, who actually does well? Patients who have got seizure at an older age. So the younger pediatric age group onsets, they usually don't do so well. There's a shorter duration of epilepsy. If you wait for 10, 15, 20 years, the outcome is not as good as those who come to us within 2 to 3 years. There is a lesion on the MRI scan, and usually it's a single lesion. Patients have got good IQ. There's an absence of psychiatric comorbidities. The lesion is limited to 1 lobe, especially the temporal lobe, and pathology like tumors do better than cortical dysplasias. Of course, completeness of resection is probably the most important predictor of seizure outcome. So these are the main things which actually indicate who will do very well after seizure. This is a little bit about the number of cases we have done in UMMC in the last 6 or 7 years. We actually had 198 patients evaluated until the end of 2018. And out of this, 137 patients underwent surgery. Out of the 137, we had 98 who went curative surgery, as well as 39 who underwent non-curative surgery. So this includes non-epileptic tumors, depth and electrode insertions, as well as vagal nerve simulators. The patients who underwent curative surgery, 87 had abnormal MRI, while 11 had normal MRI. And out of this, as I said, the majority of them are mesial temporal sclerosis, 34 patients, while 15 were focal cortical dysplasias and 38 others. This is generally our outcome over the last, when we followed these patients up for 3 years. So immediately after surgery, almost 85% of them were either grade 1 or 2. Of course, this drops down at 3 years to about 55%, close to 60%. And this is expected. We would, my next slide will show, yes. So we would see a sort of a tapering here, and this is the range we see. Most of our patients, 50% of our patients actually have got seizure control at about 5 years. We had no mortality among our patients. 75% of them recovered very well. Of course, we have to talk about complications. The majority of them had memory complication. So about 15% of our patients had short-term memory issues. 5% had motor and sensory problems, 5% visual problems, and 2% speech problem. This is the majority of the problems we've had among our surgical patients. They don't, I mean, nobody has died, nobody has surgery. Sorry. Yeah. So what is is necessary for a epilepsy surgery? We need team approach. We need a proper trained pediatric adult epileptologist. We need high quality neuroimaging. We preferably need a neuropsychologist. We need an epilepsy surgeon and experienced EEG technology. These are necessary before we start the epilepsy center. And finally, the last slide, take-home message. Neurosurgical procedures are effective treatment for patients with drug-resistant epilepsy. A referral for surgery should be considered early in any focal drug-resistant epilepsy. And if curative surgery is not an option, these patients should be considered for other palliative options to improve their quality of life. I hope if you can't take anything else, at least this first one is considered, because at the end of the day, epilepsy should be controlled. Otherwise, you are going to end up with a lot of cognitive and quality of life issues down the road. And that's one of the reasons why we are very, very adamant that these patients should have the best options possible given to them as early as possible. Thank you.